Good afternoon, and thank you for inviting me here today to talk to you about our experience of an integrated programme. We've heard this morning examples of frameworks and theories and aspirations of integration, and I've been asked to present today about a practical example of transformation and integrating care within care homes. So, I'm from a small town called Calderdale. So the map shows where we are. We're in the heart of England, although Robin thinks that Birmingham's the heart of England. We're near Manchester, and we are located in West Yorkshire, so in the Pennines. And we have a mixture of both rural and urban settings, which makes it interesting for us in the services that we commission. Our population is approximately 200,000, and from the population health management and the risk stratification that we've undertaken in primary care, we are aware that we've got approximately 16,000 people who have got a long-term condition, and fits with the slide that Robin showed earlier regarding the age range and how many conditions. We also have an ageing population, so similar with yourselves, and that ageing population stretches our health and social care resources. So why Quest? So the programme that I'm talking about is called Quest for Quality in Care Homes, and we refer to it as Quest, so I will probably refer to it as Quest, so it's just the name that we now call it. So it started in 2014, and I started work with colleagues in primary care, so GPs and social care colleagues, to talk about how we identify what additional support was required in community services to release some of the capacity in our overstretched and under-resourced primary care services. The resounding response that we got from the conversations that we had was additional support was required in care homes to support the elderly population residing in our care homes, and partly due to the fact that we were seeing earlier discharges from hospital, which was meaning that those people that were now residing in the care homes were relying on calls to primary care and GPs in order to support them. And these people had more complexities, were more vulnerable. And in talking with GPs, they recognised that actually they didn't have the skills and the expertise to manage this cohort, and they felt that it should be managed within the community and would be better managed within the community. The experience and the training of the staff were better used from the community resources, but we needed more resources in order to do that. It also would improve the access for people who require access into primary care, so wanting to visit their GP. At that time in 2014, surveys from the public were showing that access was poor into GP services, and they wanted to focus on that element of work. So what we saw was there was an increasing complex need. There was a basis around reactive care in care homes. We had had some serious care reviews. We'd had those nationally, as Robin said, but we also had had one locally. And we saw an increase in demand in acute beds, in emergency admissions, and, as I've said, in GP visits into the homes. And we undertook some analysis of our data to understand what were the top 5 reasons for people accessing GPs or being admitted into acute beds. And the 5 areas in 2014, and I have to say these 5 areas are still present now, but they are significantly reduced, but they are the UTIs, so urinary tract infections, respiratory infections, including pneumonia, fractured neck femur, senility and syncope and collapse. And that was costing Calderdale approximately £5 million of unplanned admissions. So we spoke with our senior management team in the Calderdale CCG. It was a primary care trust at the time, and we talked to our GP colleagues, and we presented the results of our findings and suggested that we commission a service around care homes, and hence the fact of Quest for Quality in Care Homes. We wrote out to our 40 care homes and asked for nominations of a pilot, and we expected roughly 10 or 12 expressions of interest. The care homes weren't always very vocal at coming forward and being part of an integrated service or working differently. We were surprised at the level of interest, and we had in phase 1 24 care homes that came with an expressions of interest. The agreed resources I had from our organisation didn't stretch to 24, so I had to go back and plea for some additional resources, as we didn't want to let people down. We wanted to test this as widely as we could, and that was approved. So the Quest for Quality was around working jointly with health and social care partners, and we started by designing a wraparound service that would be less fragmented and more integrated, with a key aim to deliver the truly person-centred approach to meet the needs of the people with long-term health, and to help make use of efficiencies and efficient use of our resources. We wanted to enhance our care home offer to provide older people with a better integrated health and social care rehabilitation programme, and we wanted to work with the multi-specialty community providers in moving specialist care out of the hospital and into the community. One of our key aims was to improve patient experience within care homes and to reduce the variation in practice across care homes. We have a large number of privately owned care homes, and due to that there is variation across the board around policies, systems, principles and ways of working, and we wanted to reduce that variation. It's very confusing for staff in other sectors to understand when all the systems and processes were different. We also wanted, as I said earlier, was to reduce the hospital admissions and attendances. And although our aim was about improving the quality, we did need to also be able to show the efficiencies in reduction in admissions and attendances. So there were 3 key elements to the Quest for Quality and the expressions of interest, which we asked care homes to apply for. The first was with regards to multidisciplinary teams, and I'll take you through that in the next slides. We also integrated telecare and telehealth systems, and again I'll touch on that briefly. And we implemented computers within the care homes, and that was to provide real-time clinical records. And it was the nurses and the GPs that said we can't access the systems or the notes in the care homes. Some care homes didn't even have a computer, so they couldn't access the notes to understand if there'd been any changes within the health records. So we provided each of the care homes with a computer. One of our learnings, and I'll touch on it at the end, was that those computers hardly got used. So that was one of the learnings that we got from the outcome of this. So if I go through to the elements of Quest. So the first element was the MDT approach. As you can see, the circle in the middle, the wraparound circle with the pink is the MDT that we wrapped around what was already existing around the primary care and the care home, and the specialist services. So the MDT consisted of an integrated model where we joined up primary care, acute or secondary services as we call it, social care, community services, and we included mental health services. Our focus and our learning from the conversations we had with colleagues and partners was this needed to be across both physical and mental health needs, and not just focusing on the physical health needs, which was what we tended to do. The Quest MDT consisted of the care home managers, the GPs, the matrons, so we invested in some additional Quest matrons is what we called them, consultant geriatrician, and again that was to link in the element of moving the specialist care out of hospital and into the community, and ensuring that there was a multidisciplinary approach with a consultant involved. We had a clinical psychologist, a social worker, and a pharmacist. One of the key areas that we learned from our research, but also once we implemented this service, was the area, the work that the pharmacist provided as part of the MDT. They undertook the role of medication reviews. They made recommendations on changing brands and stopping some drugs, some certain drugs, and avoiding residents taking unnecessary medication. And that we saw a reduction in falls due to that, and less confusion in some of the residents. The initial project, initially we started with 6 community matrons, so Quest matrons, and they acted as the leaders in undertaking the core health care. So they would undertake the assessment, they would develop the care plans, they would provide the wraparound support for the MDT, and then they would coordinate with the wider MDT partners. And they would ensure the cooperation and the collaboration as part of the integration and part of the approach that we'd implemented. The aim of the matrons was very much focused on proactive care as opposed to reactive care, which was a huge challenge because, as I said earlier, care homes are very reactive in the way that they work. What we wanted the matrons to do was to build relationships and to put in place continuity with care home staff and the residents and professionals and families. And each of the matrons were given a locality to work to. So I think initially it was 1 per locality. They then started to double up and work in 2s, depending on their area and their skills. They also developed a shared decision-making approach as part of the system and reduced duplication. So we reduced the number of different professionals going into care homes. There was a high number there was district nurses visiting, social workers visiting, numerous people we were told that were popping in daily, and people didn't know why. So the role of the Quest matron was they were the first point of contact as part of the care homes. And they provided training to the care home staff on specific areas, such as hydration and nutrition. What we hadn't realised was the amount of training that was required and the repeat training that was required because of the high turnover of staff in care homes. The MDT met on a weekly basis, and they would discuss the complex cases, and they would together develop the personal care plan for the individuals with the complex needs. Okay. So the next slide shows you some of the benefits. We've done a number of different surveys and taught people to understand the benefits over the time. So there's been fewer hospital admissions, improved self-management through increased knowledge for residents. But for care home staff, there's been a lot in building their confidence and their experience around the care and support that they provide for those residents in that home. Some of the results, so we've measured the results. From the outset, we set up some key performance indicators in order to measure the outcomes, to be able to evidence the success, because we needed to go back and be able to demonstrate that. So we've got, this slide shows the results from 2015, which was our phase 1, and then results in March 2016, which was our phase 2 of Quest. So we were able to show a 26% reduction year on year in hospital stays, 30% reduction year on year in hospital bed use, 33% reduction in emergency admissions, 45% fewer visits than to non-Quest homes. So we were able to compare the Quest, those 24 in the Quest, compared to those that weren't in the Quest. And we had a reduced saving of nearly 800k by March 2016. So some powerful results that we were able to go back. We were also able, through the surveys and the discussions with the individuals and staff, to be able to describe and demonstrate the increase in the quality of care that was provided, and not just the fact of making savings is around just the funding or the resources. Moving on. So we moved on, we got a permit agreement to move into phase 2 of this Quest for Quality and to roll this out at scale. And in rolling this out at scale, we had 17 care homes, additional care homes that came on board. We actually had a waiting list at one point, but we couldn't take them on until we'd got agreed commitment to funding. And our CCG agreed to sustain the funding due to the results that we were able to demonstrate. So we started to roll out the phase 2, and it became part of business as usual. And the next slide starts to show you, just shows you some of the dashboards that we created that was able to show how we reduced A&E attendances and unplanned admissions, and focused on contract management was a key part of this. Again, this is some more results which show where we've made an impact. GP visits to care homes. We avoided savings. We had savings of around 400k, so we had each GP practice would monthly submit how many care home requests they'd had for visits compared to the same time in the previous year, and we were able to look at what would a cost for that be. So it was quite a crude calculation, but the only one that we could do. Medicines reviewed, we saw changes in medicine, and a calculation around that was about 130k. So the second part of this was around technology, and we had, as part of, the second element was assistive technology, and I'm going to focus on telecare rather than telehealth. Telecare was more successful. It was a bit of it was a big leap of faith for care homes and for professionals to buy into the concept of using assistive technology. However, we didn't give them a choice. It was wrapped around in the bundle of the three elements, and if they wanted to be part of Quest, they had to also sign up to using technology so that we could pilot it. Telecare is provided by Tunstall Healthcare, and it provides a range of innovative sensors such as infrared sensors, detectors, alarms, all of which automatically detect incidents and alert staff to somebody falling, somebody having an epileptic seizure or leaving their bed, or even somebody who's leaving their chair or leaving a room. It will detect that. We have over 15 different types of equipment available to care homes as part of the Quest programme, and ordering is undertaken by the care homes, and Tunstall come and install the sensors within 5 days. Tunstall became the additional member of our MDT. So once we started to implement this, it became apparent they were a key integrated partner for our MDT approach, and it's now fully embedded in the homes. And I think as some of the other slides have shown, we've got some excellent results, and all of the results are due to the system as a whole, and we can't unpick them as one specific element. It is a system approach and system success. So the next slide just gives you a couple of examples of patients' experience and what we know. So the first example just describes a frequent a frail resident who would frequently get out of bed unsupported and fall. So this was prior to any Quest service and any telecare. And it would be common for them to spend time lying on the floor undetected, so the care home staff wouldn't know they'd fallen. In 1 month, it shows this one particular resident fell 20 times in that month and had frequent hospital admissions. So that was the result of the fall. The care home staff would immediately be reactive, ring an ambulance and get them into hospital. Since the installation of the bed sensors through telecare, there were 0 falls for this patient and 0 admissions into hospital. And similarly with the second example. And then for telecare falls prevention specifically, we've been able to evidence the following impacts. So what we know is in 16-17, we saw a reduction of fall-related hospital admissions by 7.7%, and 50% of the homes were showing they had a reduction year on year of at least 10%. And there was an associated saving of approximately 200k. In 17-18 and 18-19, fall-related incidents decreased by 14.9%, which was part duly to the work of the preventative and work and proactive work of Quest. And fall-related hospital admissions were reduced by 18.6%, and the associated services for those subsequent years were 300k. I will move on. So resident experience, we have a number of experiences. As I've said, we've had a number of surveys undertaken, and generally patients inform us that they feel more independent, there's more freedom, there's more dignity, and they're less frequently supervised due to the telecare system. And care homes, again, some quotes, they say that it's changed the way they work, it's less noisy, there's less disruption for both staff and residents, it's a much more peaceful environment, and it provides them some of the telecare care assist, collates all the information of the calls and how long the call has been, and provides them with evidence to be able to go back into their care homes and ask for certain additional equipment that a patient might require. So just wanted to say we've been nationally recognised in England through HSJ awards and various awards across the country. We seem to win when I don't attend, so there's something there in that. And finally, I just wanted to wrap up and capture the learning from the programme. So we've undertaken numerous audits, especially at phase 1, at the end of phase 1 and at the end of phase 2, in order to learn and improve. One of the main things has been about the changing culture and mindset required by all professionals to work in an integrated way, especially care home staff. It was difficult to implement proactive service when services and care homes work really reactively. There was a high turnover of care staff, as I said, and that was significantly higher than we had anticipated, and that meant that training was constant. And we were unaware that care staff were not computer or technical savvy, so some didn't even know how to turn on a computer. So we were really starting from the basics. It's a complex program and required close contract management. So in a way, we had to micromanage that for the first 3 years in order to demonstrate the quality and the efficiencies and the savings. It's public money. We need to be able to identify and demonstrate that. And we've embedded new ways of working. So one of the key things has been that the GPs have had significantly less calls to them asking for support. People now go to the Quest. And finally, the changes made since all of the evidence and the audits, and we've made significant changes and improvements to the Quest programme. The key points were it became business as usual. So our organisation agreed to recurrently fund this service, but it was paying for itself. Staff were integrated. It was the way we wanted to work, and it was a starter for us as a CCG on how to start to work to look at that MDT approach and integration. Providers changed the role and the skills of the team after phase 2. They started to identify gaps of skills and workforce and being able to recruit matrons. And from year 2 onwards to present, we now have healthcare assistants who support them and are a key part of the Quest team. The contract bit has moved out of the outcome-based approach, and the providers are now managing that themselves and redesigning and remodelling the service to meet the needs. And finally, as I said, we've removed the computers. That didn't work, and that's one of the learning. Not everything works, and you have to recognise and be able to recognise where things don't work and be clear about removing them from the programme. My final slide is just a quote from the King's Fund about transformation. Transformation isn't a change programme in a defined time scale. It's a state of permanent revolution, and we found that as part of the Quest for Quality in Care Homes. Okay, thank you.